Okay. Can you see my slide?
Yes, yes.
Okay. So nextly, I would like to talk about the NBI diagnosis of early colorectal neoplasm. And as mentioned by Noria, it is also very important to describe about the basic of uh, diagnosing colorectal neoplasm, including chromoendoscopy. So I will also include some of the basic concept in my talk today. So this slide shows that the logical logistic workflow of diagnosing colorectal neoplasm in our practice. So IEE modality is used in differentiating neoplastic from non-neoplastic lesion. Then we can differentiate uh, 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 cancerous from non-cancerous lesion or differentiate conventional adenoma from selected lesion and identify dysplasia or advanced histology or even diagnosing cancer. And finally, if you suspect the lesion as cancer, then we can uh, uh, identify those cancer that is indicated to be treated by endoluminotherapy and invasive cancer. So this workflow is very important to tailor patient to different treatment and different interval of surveillance. So the first step of diagnosing colorectal neoplasm is morphology. So you can see this summary table of Paris classification. Um, Different morphology carry different risk of advanced histology of even cancer. So you can see that we apply different treatment for lesion with different morphology, as you can see here. So, for example, in the retrospreading tumor, there are four subtypes. So you can see the LST granular type with homogeneous morphology or mixed nodular morphology. And in the non-granular type, we have a pseudo-depressed subtype and a flat elevated subtype. So recent meta-analysis showed that if the morphology is LSTG with homogeneous morphology, and you can see the risk of submucosal invasion is very low. So for such lesion, we can apply piecemeal EMR. Of course, you can also perform ESD, but ESD usually require longer procedure time. But in contrast, you can see that if the morphology is mixed nodular LSTG or have a pseudo depressed in non-granular type, then you can see the risk of SM invasion is very high. So we have to perform en bloc resection by ESD. So another important morphology is depressed morphology, including the Paris 2C, 2A plus 2C, or 2C plus 2A. So you can see this systematic review from four different countries. It showed that if the lesion has a depressed morphology, then the risk of um, invasive cancer or high-grade dysplasia is extraordinarily high. So historically, there are several neurobrain imaging classification systems, and it is very important to unify the classification system such that our endoscopy can communicate each other using the same classification system. So the Dr. Sano's classification system, which is actually proposed by Dr. Sano, who is the inventor of NBI system, is the very first classification system for NBI. And I think many of our audience or our doctor are quite familiar with this first NBI classification system. And then comes the nice classification. So there are three type of nice classification, dividing lesion to non-neoplastic, hyperplastic, or scissor selective polyp, or adenoma, and the deep invasive cancers. So this slide show the appearance of three type of nice classification. So this slide show the appearance of hyperplastic polyp and the adenoma. So in hyperplastic polyp, the color is usually the same as the background mucosa and are lighter in color. And adenoma usually has a darker appearance compared with the background mucosa. Regarding the vessel, usually there is no vessel for hyperplastic polyp or only some isolated lazy vessel coursing across the lesion. However, in adenoma, we can see the thick brown vessel surrounding the white structure. The capillary network is usually visible. Regarding the surface pattern, in hyperplastic polyp, uh, the dark spots are surrounded by the white crest. So this is quite different from the appearance of adenoma. So the surface pattern of adenoma is usually oval, tubular or branch white structure surrounded by brown vessels. So previous meta-analysis by Stanford group by Professor Soitikno, it showed that NBI is very useful in discriminating neoplastic from non-neoplastic lesion with a very high accuracy, as you can see here. But uh, there are some problem with nice classification. So you can see that in type 2 nice classification, it contains a benign adenoma, high-grade dysplasia, or even superficial T1 cancer, or some deep invasive cancer. So because nice classification do not use magnifying observation, so it is not so accurate in guiding treatment. And another issue is that its inter-observer agreement is not so high compared with the crystal violet, especially for the suspicious cancerous lesion. So crystal violet staining still remain the gold standard to decide whether the suspicious cancer lesion should be treated endoscopically or by surgery. So this is the JNS classification, and actually this classification is used to deal with the problem encountered by NICE classification. So you can see there are two subtype of type 2 capillary pattern, the 2A and the 2B. So 2A is a benign adenoma, whereas 2B contains some high-grade dysplasia or superficial T1 cancer. And the type 3 is almost equivalent to the nice type 3, which refer to a deep invasive cancer. So here are some of the examples showing this is the genetic type 1 lesion, and you can see the roundish surface pit, and also very scarce or lacy vessels, and the color is almost the same as the background mucosa. And this is the type 2A, and you can see a regular capillary pattern, and this is another example of 2A. And this again show the appearance of genetic type 2A. So most of the benign adenoma had such kind of appearance. And this is 2B. So you can see there is a variable thickness of the capillary. And this is another example of type 2B capillary pattern. So the diameter of the capillary is not uniform. And another example of type 2B. So this is the typical appearance of type 3. You can see there are some amorphous areas and also some interrupted capillary. So such kind of lesion is the synonym of deep invasive cancer and should be referred for surgical resection. So nextly, I would like to talk about the invasion depths. So, what is the appearance of deep invasive cancer? If you see a JNet type 3, this is a red flag of deep invasive cancer. And, oh, sorry. So, this kind of lesion should be referred for surgical resection. However, if there is no significant deep invasive appearance on the white light endoscopy and the only JNet type 2B capillary pattern is observed, and we can further apply staining endoscopy method for more detailed diagnosis. So this slide shows some of the example of deep invasive cancer. So, what are the characteristics of deep invasive cancer under a conventional view? So, if there is a presence of well-demarcated depressed area like this, or there is a 1S plus 2C morphology, or there is stiffness and expansion of the surface or easy breathing and whole convergence. This is a very characteristic appearance of a deep invasive cancer. And this very specific 1S plus 2C morphology uh, is actually the upward growth of the central depressed area, which is usually already have cancerous change of the depressed lesion, like this crown. So this is a very, very characteristic morphology of deep invasive cancer. So using the NICE classification, we can see the specificity of predicting deep or superficial invasion is not very high. You can see the overall specificity is only 70%, and even under high confidence prediction only reach 80%. So you can see that in type 2, nice type 2, they are mix up of benign adenoma and some superficial cancer or high-grade dysplasia, and nearly 7% of deep invasive cancers. How about the genetic classification? So you can see that um, in genetic classification, it can better discriminate those indicated for endoscopy treatment or from those should be referred for surgery. So you can see that in 2A, most of them are benign or high-grade dysplasia, and the 2B, there are some high-grade dysplasia and superficial T1 cancer and some with deep invasion. So in Japan, they further subclassify 2B into 2B with low irregularity and high irregularity. So you can see that by this sub-classification, you can further specify those with superficial T1 cancer and from those with deep invasion. So this slide summarizes some of the characteristics of deep invasion either under white light endoscopy or using the staining method. So it is worthwhile to introduce kudos pattern here. And probably some of our young doctor may not be familiar with the endoscopy classification. So in Professor Kudo's classification, it has a very good correlation with the pathology. So basically, type 1 PIP pattern is neoplastic. Type 2 is also referred to hyperplastic polyp or selected lesion. And type 3 and 4 are benign adenoma. And the type 5 actually represent the cancerous lesion. And the type 5 non-structure, this N referred to non-structure, represent the deep invasion, whereas type 5I refer to irregular, is a superficial cancer. So it is possible to predict the invasion using the chroma endoscopy. So in kudos type 5I, they further stratify to highly irregular and low-grade irregularity, and thereby discriminate those lesions that could be treated with endoscopy. And another classification system from National Cancer Center Japan, and show that if the 5I peak pattern is well demarcated, then such kind of lesion may already invaded deeply into the submucosal layer. And thirdly, I would like to talk about the selected lesion. So what are the challenges in detecting SSAP? It is usually flat in shape and thin and transparent, and not affecting the house rock folding and the low vascularity. All of these characteristics make it difficult to detect. And it is very important to know the most likely anatomical site for SSAP to occur. So you can see that SSAP are more likely to be detected in proximal colon, especially in transverse and ascending colon. This is quite different from the conventional hyperplastic polyp and adenoma. So this slide summarize the endoscopic appearance of selected lesion. So it is usually proximal located and transparent in shape. Transparent in its color, and have some mucus on the surface. And if we apply magnifying observation, then we can see the opening of uh, type 2 pit pattern, the type 2O pit pattern, or some surface group, or telangiectasia on the surface. And it is also very important to identify dysplasia. So this is the conventional dysplasia observed on the surface, and this appearance is quite similar to what we observe either the type 2 capillary pattern using the JNet or NICE, or kudos type 3 or 4 P pattern. And there is another selected dysplasia looks like this. So, what are the risk factors of dysplasia in selected lesion? So you can see that the 1S morphology or the OH are the risk factor of having dysplasia in selected lesion. So in such case, the patient should be followed up with a 3-year surveillance interval according to the most updated AGA guideline. So this slide show one example of selected lesion with dysplasia. So you can see the 1S part with the neoplastic appearance like this using the neurobank imaging and using the chroma endoscopy. So herein, I would like to share some of the example. So this case was provided by Dr. Sano. This is the 2A lesion and a small LST non-granular. And after narrowband imaging with magnifying observation or crystal violet staining, we can see a type 2B capillary pattern and type 5I uh, kudos pit pattern. And this case finally turned out to be a high-grade dysplasia, or what we call the carcinoma in situ. This is another example. Okay, so we can see a depressed area with full convergence. So if you are experienced endoscopist, probably you may suspect this is a deep invasive cancer. So we just use the IEE modality to confirm our diagnosis under conventional view. So you can see here the type 3 NISO classification and the highly irregular type 5I P pattern. So this lesion turned out to be a deep invasive T1 cancers. So here is another example. So this is a large lesion located at rectum, and under NBI we can see an area with different color. And after magnification, we can see the GNS type 2B capillary pattern. And if we further apply chroma endoscopy, then we can see in this area, we can see a well demarcated type 5I kudos P pattern. And this area is correspondent with what we observe under narrowband imaging with a little bit greenish color with type 2B GNet capillary pattern. So this lesion turned out to be a SM invasive cancer. So many doctors may ask whether chromoscopy is still necessary with NBI. So I show this example before finishing my talk. Okay, so under conventional view, perhaps many of our doctors may diagnose this is the 1S lesion, the protruded type lesion. But if we check the angle, we can see the uneven surface of this lesion. And if we apply chroma endoscopy using the indigo carmine dye, we can see this lesion actually is a depressed type lesion. This is a 2A plus 2C in morphology. And we can see the type 2B genet, and you can see in this area, the capillary pattern is rather irregular. After crystal violet staining, so we can see a demarcated area with type 5I kudos P pattern like this. And in a small area, we observe a highly irregular 5IP pattern. So in this specific case, even though this lesion is less than 1 centimeter, however, it already invaded into the submucosal layer deeper than 1,000 micrometers. So this case shows how important IEE diagnosis is in colonoscopy. So this is the pathology finding of this region. So cancer has already invaded deeply into the submucosal layer. So in summary, this slide show how we can proceed the diagnosis using a very systematic and logical way. So firstly, we make the microscopic diagnosis of the region, determine the size, morphology, microscopic morphology, and some subtype or retrospeling tumor. And further, we perform a magnifying observation for microscopic diagnosis. So these include capillary pattern diagnosis, surface pattern diagnosis, and the peak pattern diagnosis. And also, we have to take into account some specific condition of the patient. So some of the patients are very old. So even though there are some suspicion of deep invasion, perhaps we can choose endoscopy resection considering the life expectancy or the drug that the patient use or the location of the lesion. For example, rectal T1 cancer usually has a higher risk of regional lymph node metastasis, so our treatment should be more aggressive. So finally, I would like to share this slide with all of you. Yesterday, we had an MBIC meeting. So this is the group photo of our members. So it is very important to continue our training program even under COVID-19 pandemic. So I'm very, very happy that today we have the opportunity to co-work